Hey guys, welcome back to my channel. So we're doing the nephrology section today and we're preparing for Mrcp exam. So let's get started and let's dive into it. Today we are studying the henoch-Schwann purpura. Henoch-Schwann purpura is an IgA mediated small vessel vasculitis. This is small vessel and it occurs in small children 2 to 10 years of age. There are duplicate of overload IgA nephropathy, also called Berger's disease. 90% of cases occur in children 2 to 10 years of age but can also occur in any age group. The HSP is usually seen in children following infections such as group A streptococci and mycoplasma. In children, HSP is most common cause of vasculitis affecting the kidney. The diagnosis can easily be missed. A high degree of suspicion is required. Now, the features include a palpable purpuric rash with localized edema due to cutaneous vasculitis over buttocks and extensor surface of the arms and legs. Abdominal pain due to gut vasculitis, which may be severe in some cases, leading to bloody diarrhea, a rash, a pain, and also a pain in the arthritis, especially large joints like hips, ankles, and knees. Features of IgA nephropathy, example, pain is microscopic hematuria, proteinuria, renal failure. So pain and rash are the two main symptoms you have to remember. Treatment is self-limiting vasculitis and nephropathy is generally supportive. All patients with hypertension and proteinuria should be started on AC inhibitor is one drug you need to remember. Analgesia for arthralgia, of course, once the BP has been controlled, or if there were worsening renal function of proteinuria, she should have a renal biopsy, and if this showed changes of a crescent glomerulonephritis, then an immunosuppression regime similar to that used in renal vasculitis should be started, probably with high dose steroid in the first instant or a cyclophosphamide. Steroid plus cyclophosphamide if there is precentric glomerulonephritis. There is inconsistent evidence for the use of steroid in immunosuppressants. Prognosis is usually excellent. HSP is a self-limiting condition, especially in children without renal involvement. It usually settles within 4 to 6 weeks without sequelae. If kidney involvement is mild, around 1/3 of patients have a relapse. Now, glomerulonephritis and low complement. Immune-compressed glomerulonephritis can be classified based on normal or decreased T3. Proteinuria points to glomerular pathology. Glomerular disease with low complement level narrows down to different diagnoses. Disorder associated with glomerulonephritis and low serum complements are post-infectious glomerulonephritis like post-streptococcal glomerulonephritis, subacute bacterial endocarditis, low C3C4, SLE, low C3C4, mesangiocapillary membranous proliferative glomerulonephritis, low C3, normal C4, cryoglobulinemia, low C3C4. So this subacute bacterial endocarditis, SLE, cryoglobulinemia all have low C3, low C4, except for mesangiocapillary membranous proliferative have a normal C4. IgA nephropathy is with the normal C3. This you have to remember. Goodpasture syndrome. Goodpasture syndrome, also called as anti-GBM disease, is a rare condition associated with both pulmonary hemorrhage and rapidly progressive glomerulonephritis. Goodpasture syndrome is more common in men. Sex ratio is 2:1 and has a bimodal age distribution, peaks to 20 to 30, 60 to 70 years of age bracket. It is associated with HLA-DR2, HLA-B7. Although many diseases can present with these symptoms, the name Goodpasture syndrome is usually reserved for the autoimmune disease triggered when the patient immune system attacks Goodpasture antigen, a type 2 hypersensitivity reaction which is found in kidneys and lung, causing damage to these organs. It is caused by anti-glomerular basement membrane antibodies, anti-GBM antibodies against the type 4 collagen. This is a type 2 hypersensitivity reaction against the type 4 collagen. 30% of patients have positive ANCA serology, P-ANCA, and is directed against myeloperoxidase. Now, the features include pulmonary hemorrhage, hemoptysis following RPG, and crescentic and factors which are likelihood of pulmonary hemorrhage are young males who are smoking and they have a lower respiratory tract infection and they have pulmonary edema, and then inhalation of hydrocarbon. Investigation is linear biopsy. Renal biopsy we have to do with linear IgG deposits along basement membrane, race transfer factor secondary to pulmonary hemorrhage. Lung biopsy, here also biopsy, renal biopsy, lung biopsy, accumulation of hemosiderin laden macrophages with alveolar management, When there is a severe hemoptysis, rapid removal of anti-GBM antibody is indicated, and the best way to do this plasmapheresis is the treatment at specialist center and usually accompanied with pulse therapy of IV prednisolone and cyclophosphamide, steroid plus cyclophosphamide. Plasma exchange daily or alternate days 2 to 3 weeks. This will remove the circulating antibodies. Response is assessed by monitoring symptoms and anti-GBM antibody titers we have to see. Immunosuppression by steroid and cyclophosphamide for 6 to 9 months following remission. High dose pulse methylprednisolone instituted alongside or soon after plasma exchange has been commenced. This is then followed by cyclophosphamide therapy and high dose of prednisolone, which is very gradually weaned to a lower maintenance dose. Rituximab in refractory GBS. So mostly plasmapheresis, steroid plus cyclophosphamide, then plasma exchange, then rituximab. This you have to remember. The combination of hemoptysis, renal failure, and linear IgG deposit points to the diagnosis of Goodpasture syndrome. The ANCA-related nephropathy is associated with crescentic glomerulonephritis. Pulmonary edema associated with increased risk, but dehydration may decrease the likelihood of pulmonary hemorrhage. Studies reveal that without treatment, mortality is high as 90%. 90%. Despite treatment, the mortality of Goodpasture is 11%, and it has a high morbidity with 60% become dependent on dialysis. Patients who have lost more than 50% of the renal function at diagnosis unfortunately progress to long-term renal replacement therapy. Goodpasture syndrome, anti-GBM antibodies, IgG deposit. This also G, this also G. Now coming to Wegener's granulomatosis is a multi-organ autoimmune condition which can be fatal, associated with necrotizing granulomatous vasculitis affecting both upper and lower tract as well as kidneys, like Goodpasture only. It is rare with incidence of 5 to 10 per million. The classical triad is necrotizing granulomatous inflammation on the respiratory tract, glomerulonephritis, small vessel vasculitis. Pulmonary involvement is seen in 90% of cases and the renal involvement 85% of the cases. Now here it is same like Goodpastures only, but epistaxis, cyanotaxis, and sinusitis, nasal crusting, dyspnea, hemoptysis, saddle-shaped nose deformity, RPGM, posse immune. 80% of the patient also vasculitic rash, eye involvement like proptosis, cranial nerve lesion. Common manifestation of vaginal granulomatosis include constitutional symptoms like fever, night sweat, fatigue, lethargy, weight loss, arthralgia, ocular involvement including conjunctivitis, episcleritis, uveitis, optic nerve vasculitis, proptosis. ENT symptoms like chronic sinusitis, rhinitis, otitis, median hearing loss, subglottic stenosis leading to stridor, and feature of extrathoracic air obstruction, flow volume loop. Pulmonary disease, for example, pulmonary infiltrate, cough, hemoptysis, chest discomfort, and dyspnea. So constitutional, then ocular, then ENT. So most of the face is involved. Renal disease manifested crescentic necrotizing. Here the word necrotizing is used a lot. Glomerulonephritis. Nervous system involvement manifested mononeuritis, multiplex sensory motor polyneuropathy, cranial nerve palsies, and vasculitis of small to medium sized vessels of the brain and spinal cord. Granulomatous masses that involve the orbit, optic nerve, meninges, and the brain. Skin involvement can lead to palpable purulent skin ulcers. Investigation are positive. ANS C ANCA. In GB, Goodpasture syndrome is P ANCA. Here it is C ANCA. More than 90% of cases P ANCA positive, 25% only. Chest X-ray, wide variety of presentation including cavitating lesion because it is necrotizing. Renal biopsy, epithelial crescents in the bone and capsule to confirm directly pulmonary hemorrhage, raised KCO is seen. Renal biopsy confirms the diagnosis and guides treatment should be performed prior to starting any long-term therapy. IV pulse methylprednisolone may be commenced to renal biopsy clinical necessary. Initial preferred therapy of vaginal granulomatosis is 3 days pulse 1 gram IV methylprednisolone plus cyclophosphamide, like steroid plus cyclophosphamide. Both reduce remission in 89% of patients. Patients who are unable to tolerate cyclophosphamide, azathioprine or methotrexate may be considered as an alternative. IV pulse steroid therapy is later converted to oral prednisolone and a suitable steroid-sparing agent. Patients on high-dose steroid and cyclophosphamide are at increased risk of pneumocystis pneumonia, PCP. So clotrimazole, Septran, should be considered IVIG, plasma exchange, TNF alpha blocking agent, anti-thymocyte globulin, TTG, and monoclonal anti-T cell antibodies can be used in disease refractory to these agents. Rituximab, anti-CD20. In case of resistant to medical treatment, medical survival 8 to 9 years. The combination of pulmonary renal involvement combined with the history of chronic sinusitis points towards the diagnosis of vaginous granulomatosis. A prolonged history of epistaxis sinusitis, most commonly in vaginous granulomatosis, which of some patients also associated with eosinophilia. Rapidly progressive glomerulonephritis. It is a disease of kidney that results in rapid decrease in the eGFR of at least 50% over a short period of time, few days. Incidence UK about 2 cases per 1 lakh persons. The main pathological finding is fibrinoid necrosis. More than 90% of biopsy specimen extensive crescent RPGNS crescent formation at least 50% of the glomeruli. These crescent are collections of epithelial cells and macrophages proliferation within the Bowman capsule. The presence of crescent indicates that glomerular damage is rapid and progressing from onset of ESRT within weeks to months. The clinical presentation is similar to other genes, but there is a rapid progression to renal failure. Immunofluorescence detects IgG and C3 in the glomerular basement membrane. The three distribution immunofluorescence and crescentic luminescence absent, granular or linear. Classification of RPGN as follows: Posse-immune, immune complex, anti-GBM mediated. Posse-immune is microscopic polyangiitis, vaginous, idiopathic. Immune complexes, glomerulonephritis, SLE, cryoglobulinemia, IEC, HBV. Anti-GBM mediated, anti-GBM glomerulonephritis without lung hemorrhage, good passage disease with lung hemorrhage. So Posse-immune, immune complex, anti-GBM. Pulse methylprednisolone IV and cyclophosphamide is the treatment. Early initiation of high dose steroid has been associated with improved mortality and more rapid return of kidney function. Prognosis poor if initial creatinine is more than 600 millimole per liter. Acute tubular interstitial nephritis. Acute interstitial nephritis characterized by interstitial inflammation and edema. Left untreated, this results in interstitial fibrosis. Definitive diagnosis established vaginal biopsy, which usually shows interstitial edema with heavy infiltrate of inflammatory cells and variable tubular necrosis. Although eosinophil and gallium-67 scanning are also suggestive, 67% of cases of acute interstitial nephritis are induced by exposure to drugs. The mechanism is via delayed T cell hypersensitivity to or cytotoxic T cell reaction. This is not typically dose dependent. Multiple medications have been implicated, and the presentation lab findings vary according to the class of drug involved. Classic presenting features include fever, rash, arthralgia. Mild eosinophilia is common. Eosinophilia is pathognomic. You have to see if the urine is pouring out any eosinophils. The triad of rash, fever, and eosinophilia is seen in 10% of the cases. Agent with complicated beta-lactam antibiotic, cephalosporin, vancomycin, sulfonamide, rifampicin, quinolones. So many which are very frequently used. NSAID, diuretics, antivirals, cyclophosphamide, foscarnet, phenytoin, allopurinol, cephalosporin, omeprazole. Most very common drugs over here. The patient take antibiotic for UTI, then after 5 days rising renal chemistry, protein 2 plus, blood 2 plus, increased TL13, eosinophils, widespread erythematous rash, pruritus, arthralgia, fatigability, acute interstitial nephritis, sure diagnosis by renal biopsy. Treatment cessation, of course, steroids. Higher dose prednisolone can have beneficial effect if accelerate recovery and prevent long-term renal damage, especially if initiated early. Dialysis may be required in severe cases. In general, the prognosis of drug-induced acute interstitial nephritis is good, and partial or complete recovery of renal function is normally seen. Post-streptococcal glomerulonephritis appears 2 to 3 weeks after the acute infection, especially skin. Because strep, so skin. Serum sickness is a possibility, but it may much less common than the interstitial nephritis. Patient with herpetic encephalitis, IV or cyclovir, renal important impression and oliguria due to acute interstitial nephritis, tubular obstruction. IV doses of cyclovir, which has relatively low solubility, can lead to deposition of acyclovir crystals in the renal tubule, resulting in intratubular obstruction and foci of interstitial inflammation. This occurs more often in dehydrated patients, so that's why patient with acyclovir should be properly hydrated. The decline in renal function expected to begin shortly after the acyclovir therapy rather than 3 weeks after the therapy. Some cases, birefringent needle-shaped acyclovir crystals can be seen in the patient urine, particularly under polarized light, so the urine microscopy may be indeed add information. This condition can be prevented with prior hydration and slow drug infusion. Patient with URT and had received antibiotics therapy, then after that developed renal impairment, proteinuria, hematuria. Think of the one of these: IgA nephropathy or post-streptococcal glomerulonephritis and acute interstitial nephritis. Non-steroidal anti-inflammatory drugs may cause a reversible reduction in the GFR, acute tubular necrosis, renal papillary necrosis, acute tubular interstitial nephritis often with heavy proteinuria, chronic tubular interstitial nephritis. Now, diabetic nephropathy stages. Stage 1, hyperinfiltrating increasing GFR may be reversible. Stage 2, silent and latent. Most patients do not develop microalbuminuria for 10 years. GFR remains elevated. Incipient nephropathy. Stage 3, microalbuminuria starts. Albumin excretion of 3 to 300 mg per day. Dipstick negative. Stage 4, overt nephropathy. Persistent proteinuria. Albumin secretion more than 300 mg per day. Dipstick is positive. Hypertension present in most of the cases. Histology shows diffuse glomerulosclerosis, focused glomerulocirrhosis, Kimball-Stein-Wilson nodules called as KW nodules. Kimball-Stein-Wilson. Stage 5 is ESRD, eGFR less than 15. Renal replacement therapy is of course needed. For the purpose of Mrcp, increase in glomerular filtration rate is most characteristic of stage 1 diabetic nephropathy. It is however known that elevation of GFR usually persists in the stage 2. The timeline given here is for type 1 diabetes. Patient with type 2 diabetes mellitus progress through similar stages but in a different time scale. Some type 2 diabetes patient will progress quickly to the later stages. Diabetic nephropathy has greater incidence in type 1 diabetes mellitus than type 2. The majority of patients with diabetic nephropathy have type 2 diabetes. However, this is due to the high prevalence of type 2 rather than high incidence of nephropathy. The incidence is in fact high in type 1. Nephropathy itself is signaled by the excretion of trace amount of proteins in urine in the microalbumin area. The progression of the disease may be attenuated by stringent BP control with ACE inhibitor and strict glycemic control. In type 1 diabetes, the chance of progression to ESRD would be approximately 50%, but in type 2 diabetes with diabetic nephropathy, it is 15% to be expected to progress to SRD. A recent case study demonstrated that there is worsening of renal function in up to 45% of patients who get pregnant with pre-existing diabetic nephropathy. Any diabetic female with proven diabetic nephropathy and get pregnant, she has a 45% chance of worsening of renal function. Recommendation taken from the NICE guideline on the management of CKD, which state that when initiating ACE inhibitors therapy, a 25% reduction in the eGFR in 30% increase in serum creatinine is tolerable and should not lead to changes in dosing. ACE inhibitors should also be stopped or dose adjusted if there is a rise in the serum potassium level of greater than 6 millimoles per liter. ERB produced the same effect of the ACE inhibitor in terms of reduction in eGFR and rise in the creatinine. There is no benefit changing from one to another should the other class of drug impair renal function sufficiently that it has to be stopped. Unfortunately, a progressive increase in serum creatinine is not unusual in the treatment of diabetic nephropathy. It is likely that the increase in creatinine seen is due to progression of this patient's intrinsic diabetic renal disease rather than to any other pathology such as renal artery disease upon which ACE inhibitors may have an impact. To such, the recommendation is to continue ACE inhibitor Ramipel at a maximum tolerated dose of 10 mg daily. It will likely still be having an effect in slowing progression. Now, hematuria. Very commonly seen in daily practice. The management of patient hematuria is often difficult due to the absence of widely followed guidelines. It is sometimes unclear with the patient are best managed by primary care, a neurologist, or by nephrologist. The terminology surrounding hematuria is staining. Microscopic or dipstick positive hematuria is increase termed non-visible hematuria, while macroscopic hematuria is termed as visible hematuria. Non-visible and visible. Causes of transient or spurious non-visible hematuria is UTI, menstruation, vigorous exercise, sexual intercourse. So all these can lead to non-visible hematuria. Cause of persistent non-visible hematuria: cancer, stone, BPH, prostatitis, urethritis, renal causes like IgA nephropathy, thin basement membrane disease. Now, management: current evidence does not support screening for hematuria. The incidence of non-visible hematuria is similar to patient taking aspirin, warfarin to the general population. Hence, these patients should also be investigated as normal. Now, testing is urine dipstick is a test of choice for detecting hematuria. Urine microscopy may be used, but time to analysis significantly affects the number to red blood cell detected. Nice urgent cancer referral guidance of any age with painless macroscopic hematuria. When to refer is a macroscopic hematuria, age 40 years or older, present with recurrent or persistent urinary tract infection associated with hematuria, age 50 years and older, were found to have unexplained macroscopic hematuria. Now, renal stones. Risk factors like dehydration, hyperparathyroidism, hypercalcemia, hypercalciuria, cystinuria, not cystinosis, high dietary oxalates, renal tubular acidosis, medullary sponge kidney, polycystic kidney disease, beryllium and cadmium exposure. Risk factors for urate stones is gout, ileostomy, loss of bicarbonate and fluid results in acidic urine causing the precipitation of uric acid. Now, the drugs that cause are drugs that promote calcium stones like loop diuretic, steroid, acetazolamide, theophylline. Thiazide can prevent calcium stone, increase distal tubular calcium resorption. Oxalate stones are uncommon in dietary excess of oxalates. However, enteric oxaluria may occur in a number of disorders in which malabsorption results in excessive colonic absorption of oxalate. These include celiac disease, Crohn's disease, chronic pancreatitis, and short bowel syndrome, post-jejunocolic anastomosis for Crohn's disease. High fluid intake and calcium carbonate are mainstay of prevention. 20-year-old boy admitted with renal colic due to renal calculus. His mother has a similar history of renal calculi. The most likely explanation for recurrent renal calculi in both mother and child is idiopathic hypercalciuria. Idiopathic hypercalciuria has a familial or sporadic pattern. Familial pattern: autosomal dominant inheritance seen. Obviously, there is normal serum calcium, but raised urinary excretion of calcium. Increased 24 hours urinary calcium is 18 millimole per 24 hours. The type of this is identical infected members of the same family and the typical presentation of recurrent urinary calculi. Treatment is high fluid intake. Aim for daily urine output of more than 2000 ml. Reducing his dairy intake. Reduce GIT absorption of calcium. Thiazide diuretic. Fluid, milk, and thiazide. Reduce renal tubular calcium excretion and therefore can prevent calcium stone formation. Potassium citrate also chelates. Citralca is called over here. Chelates calcium is useful in combination with thiazide in those who develop hypokalemia on diuretics. Medullary sponge kidney disorder which can affect part 1 or both kidneys, resulting ectatic and cystic changes in medullary and papillary collection. Dark is often associated with calculi which can result in pyelonephritis and renal tract obstruction. Medullary sponge kidney is typically non-hereditary and is a congenital condition. The etiology is uncertain but is thought to be development abnormality, possibly resulting in tubular collecting tract obstruction at early age. Majority of cases are sporadic, although rare autosomal dominant familial form exists which onset in adulthood, and a juvenile autosomal recessive form is also recognized. Recent research has identified a possible defect in the development of a proton pump mechanism in the kidneys. Now, renal stones imaging. Calcium oxalate radiograph appearance is opaque. Mixed calcium oxalate phosphate stone opaque. Triple phosphate stone opaque. Calcium phosphate is opaque. Urate stones are radiolucent. Cystine stones is semi-opaque ground glass appearance. Xanthine stones are radiolucent. XU is lucent. The most common composition of renal stone in general population: calcium oxalate followed by calcium phosphate. Together, these make up a significant majority of stone. Calcium phosphate stones in renal tubular acidosis. Staghorn calculi composed of struvite, ammonium magnesium phosphate, triple phosphate, form an alkaline urine classically produced by urea-splitting organism, ammonia-producing bacteria such as urea plasma, urealytium, Klebsiella, Proteus. It was renal pulverization extended up to 2 calyces. Treatment: antibiotics, urease inhibitors, urine acidification, vitamin C. Renal stone X-ray, cystine stones are semi-opaque, urate and xanthine stone are radiolucent. Now, renal stone management is acute management. Renal colleague British Association of Urology recommended diclofenac, IM. Diclofenac in IM oral analgesic of choice. Widespread use of alpha adrenergic blocker to aid urethric stone passage. Alpha blocker, alpha antagonist. Diclofenac use is now less common, yes, following the MHRA warning about cardiovascular risk. It is therefore likely the guideline will change soon to an alternative anesthetic such as naproxen. Imaging: patient present in the emergency department usually have a KUB X-ray, shows 60% of the stones. Imaging of choice in non-contrast CT. 99% of stones are identified on non-contrast. Many GP now have a direct access to non-contrast CT. Stone less than 5 mm will usually pass. Lithotripsy and nephrolithotomy may be for severe cases. Prevention is hypercalciuria found in 5-10% of general population is high fluid, low animal protein, low salt, low calcium, has not been shown to be superior to normal calcium diet. Thiazide diuretics increases distal tubular calcium resorption. And oxalate stone, cholesterol reduces urinary oxalate secretion. Pyridoxine reduces urinary oxalate secretion. So cholestyramine and pyridostigmine. Uric acid stone, allopurinol, urinary alkalization like oral bicarbonate. Now, cystinuria is an autosomal recessive disorder characterized by recurrent renal stones in young age. Cystinuria is commonest inborn area of amino acid transport due to effect in membrane transport of cysteine, ornithine, lysine, and arginine. Cola. The glomerulus is unable to resorb these amino acids, so accumulation of cysteine in the collecting system, and they are therefore excreted in the urine. No functional defect within the glomeruli. No cysteine deposit within the cornea. The RBAT gene is responsible, and there are 3 forms distinguished by the pattern of tubular amino acid transport. Genetics is chromosome 2, SCL3A1 gene, and chromosome 19, SCL7A9, chromosome 2 and 19. Features are recurrent renal stones in the form of cystine stones, which are often bilateral, multiple, and can form staghorn, yellow crystalline, and semi-opaque on X-ray. Diagnosis: stone analysis, cystine cyanide nitropeside test. Management is conservative, good hydration, D-penicillamine as a chelation therapy, urine alkalization with bicarbonate. Cystines are not easily broken. Biolizotrypsin, therefore, percutaneous removal is most often used if they do develop. The cystines are radio-opaque with presence of sulfur. On plain film, which will not use as much as in UK and more, they are radiolucent. Cystine stone XU is LU. On CTs, almost all cystine stones are radio-opaque. Homocystinuria is a rare autosomal recessive disorder caused by deficiency of cystathione beta synthase. This results in accumulation of homocysteine, which then oxidizes to homocysteine. Features are fine, fair hair, skin malar flush, libido reticularis, musculoskeletal may be similar to Marfan syndrome. Neurology and psychiatry in up to 60% of cases, pyramidal tract symptom, learning difficulty, mentally retarded, behavioral problems, seizures, ocular downward dislocation of the lens. Marfan has upward light towards the fan, dislocation of lens, increased risk of arterial venous thromboembolism, except for coronary, but may present with an MI. Diagnosis is urinary homocysteine level, measuring cystathione synthase activity in liver biopsy. Cyanide nitropeside test, which is also positive in cystinuria. Treatment is B6 and folic acid. Homocystinuria is caused by deficiency of cystathione beta synthase. Interestingly, patients with Down syndrome have an excess of cystathione beta synthase. Renal vascular disease is commonly due to atherosclerosis. More than 95% of the patients are associated with risk factors such as smoking and hypertension that cause atheroma elsewhere in the body. Sorry about that. It is associated with risk factors such as smoking and hypertension that cause atheroma elsewhere in the body. It may present as hypertension, chronic liver failure, or flash pulmonary edema. In younger patients, however, fibromuscular dysplasia needs to be considered. It is more common in young women, 30 to 40 years, and characteristic of the string of bead appearance on angiography. Patient respond well to balloon angioplasty in 30% of cases. Disease bilateral. Limb arteries with peripheral vascular disease can be affected by fibromuscular dysplasia, but this occurs only in 5% of the cases. Arteriosclerosis. Renal arteriosclerosis is more common cause of RAS than fibromuscular dysplasia. 40% may have peripheral vascular disease with intermittent claudication. There may be proteinuria. Investigation is MR angiography is non-investigation of choice. CT angiography. Conventional renal angiography is less commonly performed used nowadays, but may still have a role in planning a surgery. MR angiography should be considered the optimum non-invasive screening test for renal vascular disease and can be performed safely in patients with CKD stage 3 and 4. However, there is increasing concern regarding gadolinium-related nephrogenic systemic fibrosis, and guidelines may therefore change in the future. Flash pulmonary edema, UAE worse, urinary symptoms worse on AC inhibitors, asymmetrical kidneys, renal artery stenosis, do MR angiography. Current UK guideline with regard to CKD recommend referral for further investigation of atherosclerotic renal artery stenosis when there is refractory hypertension, BP more than 150/90 despite 3 antihypertensive, recurrent episode of flash pulmonary edema despite normal left ventricular function, raise of 20% serum creatinine, a fall of GFR more than 15 over 12 months within the high clinical suspicion of wide breast atherosclerosis during the first 2 months after initiation of AC inhibitors ARBs. Treatment is stop AC inhibitors. Non-AC inhibitor control BP like CCB. Start aspirin and statin. There is little or no benefit of angioplasty in RAS, although it may be appropriate in patients with recurrent episodes of pulmonary edema. Any patient with bilateral RAS or stenosis in respiratory functioning kidneys is a candidate for revascularization procedures. Renal artery stenosis is a potential cause of hypertension. Typical patients are vasculopathies. Poor prognosis, 80% mortality at 5 years related to concurrent coronary disease. It is almost exclusively caused by atherosclerosis, but other causes include fibromuscular dysplasia, vasculitis, external compression. Typical ultrasound changes the asymmetrical kidneys. The affected kidneys are more than 2 cm smaller than the unaffected kidney. AC inhibitors are contraindicated in renal artery stenosis as they inhibit contraction of the efferent arteriole which promote glomerular filtration in the disease. A rise in creatinine of 15% from baseline is expected with commencement of AC inhibitors. A large rise in creatinine like more than 20% should warrant a search for renal artery stenosis given in the likelihood of vascular disease. The association of a flash pulmonary edema and hypertension in a young patient less than 50 years with no obvious cardiovascular risk factor point towards fibromuscular dysplasia. Treatment is angioplasty. Pulmonary edema patient present with frothy pink sputum. Young female 30-year-old with sudden onset breathlessness while eating dinner with cough and frothy pink sputum, high BP 160, flash pulmonary edema, fibromuscular dysplasia. Congenital RAS is extremely rare, may be associated with coarctation of aorta. When AC inhibitors is started, non-progressive rise in creatinine 20-30% is acceptable. Progressive rise in creatinine more than 30% is drop consideration of a RAS. Guidelines generally suggest checking serum creatinine within 1 week, 1 month, then periodically after starting AC inhibitors. So guys, that's all for now. Okay, bye-bye.